This presentation first went live at the end of September 22 as part of the second medical symposium prior to the final game of the 2022 season of the European Football League between the Hamburg Sea Devils and the Vienna Vikings. The symposium schedule focused on the specific demands of medical supervision of American football athletes. This presentation in special has been set up in order to emphasize the importance of the utilization of objective criteria for determining the biomechanical status and its potential impact on injury risks, recovery, and overall performance. In the situation of a longer-lasting injury, the progress of recovery is of highest interest from the moment on which the injury occurred on. That is what the title of this presentation stands for. The decision on when the athlete gets cleared for a safe return to physical activity is crucial to any further development of performance and potential re-injury. It should be taken on the best available objective criteria. The following slides use American football as an example to point out the importance of a biomechanical screening and recovery as well as a preventive action, whereas the basic idea can be easily transferred to athletes of any sports. DIERS International addresses a large field of medical professionals. Medical devices for posture motion analysis, surface EMG or isometric force measurement enabled a good entry to the athletic world, equipping medics of various sports teams with effective tools for biomechanical assessment of their athletes. DIERS looks back at more than 25 years of market presence, in which the application range has largely expanded from classic orthopedics in the early years to physio and podiatry, and later to dentistry, orthodontics, osteopathy, chiro, and of course sports medicine. When we are talking about injury, it most likely all starts on a match day, which, keeping it with American football, will be a Sunday. Players deal with hits, tackles, bumps, they fall, get tackled or smashed to the ground or against an opponent, resulting in bruises, strains, contusions and what have you. This all gets taken care of during the next day. This is when players charge up, recover or simply get right again using various measures of physical recovery. This is what we can define as a best-case scenario in which the athlete gets back to action quickly. But if your starting quarterback gets carried off the pitch with his leg casted, you will know that things do not get settled within a single get-right day. From this moment on, the essential question is, how long will he be out? And this is when the wheels of an entire universe get turned on, where everybody tries to understand the situation and how long it would take to get over it. And as the medically responsible and most capable person in that group, it will be the medic to whom all those questions will be addressed. So, the question, "Doc, how long?" will be the most frequently asked and require the team physician to make a firm statement that, in the upcoming course of events, in the best case provides guidance and in the worst case the binding commitment of the practitioner. That's when the medical head needs to mediate between entities and respect differing aspects. The central motive for the player might be the continuation of his career, maybe a pending contract situation, thoughts about his contribution to the team, but clearly also a non-neglectable fear of re-injury. Coaches and owners may focus more on non-individual aspects like team success and return of invest that is based on the achievement of season goals and merchandise that comes with it. And, despite the stereotype image of a reckless and profit-oriented team official, the athlete's health and well-being is an equally important factor for coaches as well as managers. But on a daily basis, the interests of the athlete are the ones the medic needs to deal with. Here, the fear of re-injury is a crucial intervention point. Taking a look at science, this article proves right what many see the abbreviation NFL really standing for. That's not for long. Not every player is granted with a long career like Brady or Rodgers. An average career longevity of only 3.3 years opens a rather small window for an athlete to generate an adequate income. A 3-year span in a 17-game NFL season results in a sum of most likely not even 60 professional games. Missing games due to injury results in a significant decrease of even more games after return to play, accompanied by a reduced overall performance. With the example of ankle sprain injuries, we can see a linear incidence progression with an average inactive time of 11.5 weeks, but ranging up to approximately 19 weeks and plus. A standard deviation that high gives us a good idea on the variability of a return-to-play time frame, which emphasizes the uncertainty that comes with an injury. In order to have a straightforward return to play routine, the implementation of standards and protocol-guided clearance procedures are of highest priority. This will build up objective criteria which all participants of a recovery process can follow along, reducing the subjectiveness in defining how long he will be out. Even established protocols have potential to fail, like in October 22 when the NFL's concussion protocol had been put to question after several apparently subjectively motivated decisions by the medics in charge who cleared players with obvious symptoms too early. For sure, it takes all of the before-mentioned players to commit to a standard in order to make it objectively applicable. Now, let's focus on the biomechanical screening again. In this first part, we will turn the spotlight to a simple static assessment. Here you can see some interesting footage of a professional football player. The subject is a 30-year-old, 7-year NFL veteran playing at guard. The exam has been conducted in an habitual standing position, taking 6 seconds overall and delivering a synchronized sample of spinometry, leg axis and foot pressure distribution. Mind that an exam like this can represent an initial screening, an injury situation or a moment during the recovery process. Depending on the setting, we would look slightly different to our results. Let's have a deeper insight. Now, as for the upper body orientation, we may look at the sagittal profile in more detail. We can observe a trunk inclination and a serpar-kyphosis angle of 59 degrees. That is the quantifiable part, but the sagittal profile also gives us the impression of a flattened mid-thoracic spine coming along with sharp turnings at T5 and T9 and a widespread ventral opening of the lumbar spine, creating a severe approximation of the rear ends of L2, 3 and 4. The coronal plane leg axis shows a knee valgus tendency, hip adduction and a possible internal knee rotation on both sides. In the sagittal plane, the knee shows up in full extension, which could be a little less for an habitual standing posture. The foot pressure shows a rather balanced distribution, with lowered longitudinal arches in both feet. Let's move on to part 2 of the assessment and take a look at the dynamic profile. In this exam, the subject runs at 8 miles in a fully synchronized treadmill setup in which samples of spine, 4-plane leg axis and foot rollover got acquired simultaneously. The spinometry visualizes a pelvic drop bigger on the right. Finding this in mid-stance would be a sign of weak glutes on the left, similar to Trendelenburg signs. We can also see a unilateral pelvic rotation to the right, which could indicate a psoas tightness on that side. And there still is a mid-thoracic flattening, which now gets accompanied by a second flat curvature right below the upper, together with a severe trunk incline. Well, for offensive linemen, the sagittal alignment can come in quite practical. The straight part delivers bone stability to withstand cranial impacts without muscular overload. And the inclination should be part of the biomechanical profile of an O-liner. Jumping forward from the scrimmage line, arms up, blocking and protecting the pocket, is demanding a certain repetitive body orientation and surely affects the essential biomechanical nature. In the moment prior to the initial ground contact, the knee shows up fully extended. Again, we are looking at a functional reaction that redirects the impact of ground contact of a 300-pound, 140-kilo mass from muscular absorption via eccentric activation of quads and glutes to a passive bony construct built up by pelvis, femur and tibia. This can cause an overload in the connecting joints. When we are talking about gait or running analysis, we are addressing a rather complex sequence which mostly doesn't allow for more than a subjective impression on an athlete's functional capacities. In many situations, it is suitable to reduce the full motion pattern to an ultra-short time frame or even single image that can be taken for a representative quantification. Now, when changing the viewing direction, there are some more conspicuous details to observe. Once more, we make use of shortening the time frame, which uncovers the functional impairment rather well. As the foot touches the ground, the subject's mass creates a ground reaction force he needs to withstand in a functional manner. In the coronal plane, we would expect some increased eccentrics of hip abductors. Performing that kind of knee valgus, an internal rotation helps reducing the lever acting between hip joint and gluteus medius. Simply spoken, the observed movement pattern performs an approximation of the structural leg axis on top of the support base, therefore increasing the passive shock absorption by reducing the functional response. Putting this into a representative single image, the subject moves to mid-stance in a 22-degree hip adduction and a 12-degree knee valgus. Imagine now the match situation, in which the player explodes from the scrimmage line, thereby accelerating 140 kilos and at the same time an opponent crashing in from the side. The supporting leg axis will need higher stability in order to prevent itself from collapsing laterally. The found leg axis may not be able to provide that rigidity, increasing the risk of an injury to the ankle or the knee. The pedobarography sample concludes this case by indicating a clear step length asymmetry with an extended stance phase on the right foot. This could be a sign for limited hip mobility on the opposite side. The presented findings have been connected with a lot of woulds and coulds on the diagnostical side, not giving you a clear idea on what is the detailed situation in this athlete. Well, as we don't know much about further anamnesis data, the plain results of such a screening provide only variably interpretable results. As soon as further information on acute symptoms, injury history, or additional diagnostics add to the whole picture, the interpretation of such data gets much easier and leads to clearly identifiable functional connections. This leads us to the question of how to integrate a biomechanical screening to your daily workflow. An exam taken in off or pre-season can be seen as a reference for any further exam of the same subject. We can expect the player to be free of any compensation triggered by physical demands during competition. Follow up on this reference during the season. Visualize how posture or motion change due to fatigue or exhaustion. How does a prevalent injury affect the functional profile? Can we even derive potential keys to injury when looking back at the reference scan? Visualize the status of recovery and how close the functional profile is to the reference. Clear your athlete back to practice or competition based on objective criteria. This will increase trust in the decision at your side as well as at the player's side. In order to sum things up, don't mess around with a big variety of potential diagnostics. Build up an assessment protocol which is representing a fixed order of selected diagnostics and which is able to give you the right answers in a repeatable way. Make things shout out loud in order to objectively present the recovery status of your athlete. And rely on objective criteria when clearing a player back to action. This all defines how long he will be out. I truly hope that this presentation was useful in making you aware of the potential of a biomechanical assessment tool in treatment and supervision of athletes. Thank you so much for the attention. Also a big thank you to Olaf Bark as one of our DIERS power users and head of medical commission of the ELF for organizing the medical symposium for the second time and giving DIERS the opportunity to present ourselves to an interested audience. We would be enlightened to be a regular contributor to this congress.